Hey, good morning, everyone. As one of the few people in the room that is from Chicago and lives in Chicago, welcome to Chicago. August in Chicago is something really special, and we're glad to have you. I'm an endocrine surgeon by background. My name is Wrenn. I'm practicing at Rush University Medical Center, which is one of the larger tertiary care centers in Chicago, and I've been doing RFA since 2021. And I'm here to share the guidelines, which is not the sexiest topic, but is definitely an important topic if you are launching your RFA practice. Because your patients are going to expect you to be familiar with the guidelines. And as you all know, if you start a new technology, if you're starting a new practice or a new program in RFA, you might be under tight scrutiny or have the magnifying glass on you. And so you want to make sure that you're comfortable with doing things by best practice and not getting overly experimental. And following the guidelines is a great way to stay safe, especially in the early days of your practice. So let's go ahead and jump into it. These are the objectives for our talk. We're going to be talking about what are the guidelines and how can you apply them to your RFA program. And I'll start by just saying there's not one set of omnipotent guidelines that exist. There's a couple different papers that are out there that are useful. I'm going to touch on 2 or 3 of them, but this is by no means the only set of guidelines. That being said, I think this paper is a pretty landmark paper. There's a couple people that are, I think Dr. Beck is on this paper, and amongst a lot of big names. And I think it's quite an accomplishment that this paper was able to get 8 or 9 different societies of multidisciplinary. You have endocrinology societies, you have surgical societies, you have head and neck and radiological societies, all coming together to provide guidelines on best practice in RFA. And so a lot of this talk is going to be centered on this particular paper, but there are certainly other ones that I will touch on as well. So obviously you're not going to be able to read all this, but this is just kind of the laundry list of the guidelines that they go through, and I'm going to kind of go through some of the more important ones one by one. Like I said, there's a lot of them. But I think this is probably one of the most important ones, and it is right at the top. Recommendation 1. Ultrasound-guided ablation procedures can be used as first line for patients with benign thyroid nodules that are causing symptoms or cosmetic deformity of the neck. And I say this is probably the most important guideline because this is going to be the bread and butter of RFA. The vast majority of patients that are going to come in that are going to desire RFA are non-functional benign nodules that are just too big and they're causing issues. Maybe they're growing, maybe they're causing early compression or significant compression. But either way, it's important to know that we have a number of different societies that agree that this treatment is first line right along with surgery, which is the traditional gold standard treatment for these. And so I talk to the patients about this as I go through my talk, and I'm usually talking about surgery. I'm a surgeon. I'm also talking about RFA. I'm comparing the different expected outcomes with them, and I'm letting them know what they can get from each procedure. But I make it clear to them, because for our folks who aren't coming from America, in America we also have to deal with insurance companies. And so part of this talk is also useful, and knowing the guidelines is also important from the background of dealing with insurance companies and obtaining prior authorization and approval for your patients so that they can get access to this procedure. Because while insurance access overall I think has become pretty good, and the vast majority of my patients are able to get this procedure covered, occasionally an insurance company will say, this procedure is experimental. And then when the patient gets that answer from their insurance company, then I feel like that makes me look a little bad. It makes me look like I'm experimenting on my patients. So I don't accept that answer from them, and I let them know that your insurance company might tell you that this is experimental, but let's look at these guidelines and let's say, you know, this is actually a number of our best societies coming together to agree that this is an accepted, safe, first-line treatment. So definitely important right there. I'm sorry, this slide, the boxes, my little yellow and little black box got kind of messed up, but the guidelines go on to talk about a couple other situations where this is more second line. I mean, we'll touch on these a little bit later, but benign cold nodules, first line, and then you have toxic or autonomously functioning thyroid nodules, in which this is kind of considered a second line therapy. You have papillary thyroid cancer or recurrent papillary thyroid cancer, which this is often considered a second line treatment for, but there are situations where it might be the most appropriate treatment. You know, I mentioned that we're having to talk before the procedure, and all of these recommendations I think should be common sense, but just like any patient that you'd be advising medically, or you're getting them ready for surgery if you're a surgeon, you're going to be evaluating them comprehensively. Of course, you're going to be evaluating their ultrasound, the risk of their different nodules, their thyroid function, their medical history. You're going to be talking to them about their options. You're going to be letting them know about the risks and the benefits of the procedure. And so I think that these guidelines are really just saying, you know, you have to talk to the patient and guide them through this process. We talked about this with somewhat during the hands-on portion, but I do recommend performing these predominantly under local with an oral anxiolytic medication. You know, I have done a few of these under like a deeper MAC with anesthesia present, and I think it's a little bit harder to get good verbal feedback from the patient and to keep them cooperative. And so I think it's best in general done under local, but it can be done under different settings. For the surgeons in the room are very comfortable with this concept, but prior to a thyroid interventional procedure, there should be some degree of voice assessment. And that can vary in terms of what you want to do for your voice assessment, but at the very least, you're going to be talking to the patient prior to the procedure, and you're going to be talking to them about if they've had subjective voice problems. You're going to be evaluating their phonation in clinic and evaluating their voice objectively as well. And you will decide when it is appropriate to do any further investigation, such as laryngoscopy. You know, when I started my practice for RFA, because I was launching a new program, it was the first program at Rush, you know, I made the decision that because I'm not using nerve monitoring like I'm doing during surgery, that I was going to do a laryngoscopy for every patient and preoperatively just to get that view and to assess them. And while I don't think that that's necessarily necessary, you know, I definitely think for anyone that has had a prior central neck procedure, for anyone that has any, you know, subjective voice concerns, you need to have a laryngoscopy evaluation or evaluate their cords, and whether that be an ultrasound guided look at, as Dr. Beck, you know, brilliantly showed us, you can visualize the cords via ultrasound. If you don't do laryngoscopy, you can refer them to an ENT colleague. But either way, you should have something documented that you've assessed their voice. Same goes for the post procedure. If you have a patient that is experiencing or complaining of voice changes following your RFA, that should not go ignored, and it is your duty to have that investigated, and that would usually mean get a laryngoscopy. And that could be you doing it, or it could be one of your colleagues. These guidelines also touch upon some of the other options. You know, I think at least in the United States, radiofrequency ablation has really taken off, and in terms of familiarity and you know, having the support and the right people, RFA is still number one for sure, definitely for my practice. There are different situations where RFA might not be the most appropriate choice, and I think the main one would usually be a purely cystic nodule that doesn't have any solid component. And so usually for that one, based on papers that we have, ethanol is still the most appropriate choice. I was talking to some of you guys during the hands-on session. There are plenty of nodules that have a mixed cystic and solid component, and I think RFA works really well for those. And the literature supports that too. But usually for those, if there's a big fluid component, I'm going to do an ultrasound guided aspiration at the beginning of the procedure and then ablate the solid component. As you all know, within the RFA world, we're not thinking in diameters or nodule size, we're thinking in nodule volume. And so, whether or not it be you that does this or one of your radiology colleagues, any ablated nodule or any nodule that you plan to treat should have volumetric analysis prior to the procedure. And in my procedure note, I'm including any treated nodules and their baseline volume and characteristics. And so typically that involves in the preoperative or the pre-procedure visit, getting the X, Y, and Z coordinates of the nodule and calculating the volume, and so that can be tracked over time. And it's the air and water show right now, so the parking jets that are usually flying over. Oh, and so in terms of calculating the volume, if you're not used to doing that, there is an equation. There's actually a couple equations that are commonly used. I would highly recommend using the ATA website because the ATA thyroid nodule calculator allows you to put in up to 4 different volumes, and it will track the interval change in volume and the overall change from your baseline over time. And so usually when I'm in clinic, I'm getting the size of the nodule, I'm just plugging it into the calculator. I can even do it in front of the patient, and then I copy and paste the volumetric findings right into my note, and that's how I'm following these patients. So that way you don't have to do a lot of math in the clinic because no one wants to have to do that. We talked a little bit about the transismic approach during our hands-on session. I think there's a fair lot of evidence that this is the safest way to approach RFA, and I would highly encourage everyone to get comfortable with the transismic approach and get comfortable with using the longitudinal view to see the entire needle course. And definitely that is something that you can do by changing your FNA approach so that you do it that way too. And then slowly withdrawing, utilizing the moving shot technique, and being aware of the danger triangle and the medial aspect where we all know the recurrent lateral nerve sits. I put an additional pseudo-danger triangle at the other side because as some of you know, the vagus can sometimes lie to the medial side of the carotid within the carotid sheath. And so if you're too far lateral, obviously you don't want to ablate the carotid, you don't want to ablate the vagus or the sympathetic chain and cause Horner syndrome. So there's a lot of different complications that could come by being too lateral, and there's some complications that could occur by being too medial in the kind of medial or classic. This would be the classic danger triangle. And the good thing about the transismic approach is that essentially it makes it impossible to hit that danger triangle because the trachea is there. And so unless you're going through the trachea, you're not going to hit the recurrent laryngeal nerve. And so I think when done effectively, the transismic approach makes those nerve injuries in terms of causing a recurrent nerve paralysis very hard to do. And I've never seen one personally. And so again, the moving shot technique is considered best practice, only delivering energy or only having the machine on when you see the entire needle and especially the needle tip. And then if you're not getting good visualization like we practiced earlier, just turn the machine off, readjust your probe, find yourself, and then safely turn the machine back on. Wait. Readjust your trajectory, ablate, watch that impedance rise, pull back, ablate, hit it again, keep going. And I should also mention that, we all saw this earlier too, but once you hit a particular region, like in this case, I'm ablating pretty superficial here, you're not getting very good visualization of the deeper structures, which is why we recommend going from the deep to the superficial, because that hyperechoic change causes posterior shadowing. And so your best visualization of the nodule is going to come before you start any ablation. And then as you continue to ablate, your ultrasound view of that nodule is continuing to get more and more distorted. So it's a really good idea to get the deeper, which is the more dangerous stuff, out of the way first, and then you get to the more superficial stuff as you move. Recommendation 18 from the guidelines says that the nodules need to be followed over time, which is of course intuitive, but it's important to know that someone needs to be doing that, and to know that, is that going to be you, or is that going to be one of your colleagues? Perhaps if you're not an endocrinologist, maybe if the endocrinologist that referred the patient to you wants to follow the nodule, but I think it's important when you're establishing the program to establish expectations for how the nodule is going to be followed and who's going to be doing that. And that typically means that the nodule is going to be followed at set points in time. The guidelines differ on this, and I don't think there's any one set answer. But from my practice, it's been ultrasound examination of the nodule with a volumetric calculation at 1, 3, 6, and 12 months after the ablation, and then yearly after that. But again, I think that for some people, that's overkill, and I've definitely had patients that come in from farther, and we tell them they don't need to come in that much, because especially early in the program, it's mostly for you in terms of you want to know what your outcomes are and how your nodule is doing, and the patient's going to be doing just fine out there. And so, in general, you're going to be calculating the volume. You're going to be keeping track of your outcomes. If you're not the one calculating it, then you're going to be communicating with the other doctors that are on the team, so that you have a sense of how you're doing with your procedures. And so we are all coming from different backgrounds, whether we are endocrinologists, interventional radiologists, ENT surgeons, endocrine surgeons. There are many people that are highly qualified to perform thyroid RFA. Depending on what your background is, you might need other people to help you with that process. If you are not someone that typically follows these patients over time or does the assessment of their thyroid function, you might need an endocrinologist to assist with that. If you're someone that is not from a surgical background, you might need to have a surgeon available if you get one of these rare complications that could require a surgical assist. But either way, in general, like most care in modern medicine, it takes a team. And to make sure that as you start your program that you have the right people in your place to support you, especially if something were to happen to a patient. And to obtain the appropriate training before you start, which is part of the best practice recommendations. And that could involve attending a course like this or having a proctor early on. This is a different paper, and this is a great paper for people starting a program. It's actually tailor-made for people that are interested in RFA and want to start a practice. And it's the best practices on how to do so safely. And this is a paper that you can show your hospital administrators in terms of, look at all these things I'm doing. This is all by the best practice. It includes a checklist with a check-by-check thing. You guys probably can't read it, but it includes pre-procedural checklist. Have I evaluated the ultrasound features of the thyroid? Have I ensured benign cytology? Have I talked to the patient about the realistic expectations about how the nodule is going to react to the ablation session? Have I reported their allergies? Have I evaluated their medications to make sure they're not on anticoagulation? You know, all these important things to consider that might not be immediately intuitive. It's a good thing sometimes, again, especially early on, to have a checklist just to make sure that you're doing things appropriately. And post-procedural or pre-procedural things, deciding what my initial energy is going to be, deciding what my probe size is going to be, how am I going to make the patient comfortable? How am I going to do my local anesthesia or my anxiolytic medication? This covers literally everything. So going back to the initial guidelines, having familiarity with neck ultrasound is definitely essential, and I think most people in this room kind of share that in common, is that you have familiarity with thyroid ultrasound. But if not, that's okay. You just get comfortable with it, and definitely get good at thyroid ultrasound and head and neck ultrasound prior to starting an ablation program, of course. Being proficient with FNA, I don't think is 100% a necessity, but I think it definitely helps. And I talked to a lot of people during the hands-on session that for the year before I started my RFA program, I did all my FNA biopsies in the longitudinal plane via the transismic approach, just so that I was always 100% confident that I always was going to get the needle into the nodule perfectly and visualize that needle. And then when it was time to do my first RFA session, it really wasn't very stressful at all, because I knew that I was going to be able to get the needle right there, and then it's just a matter of turning the machine on. And then having some supervision. And I think that one of the things that StarMed does great is making sure that as you start your program, that they help support you. And early on, this photo is actually taken from my very first ablation, and I had someone from StarMed there with me to make sure that all the technical aspects were there, and we had someone available. I didn't actually have another physician in the room, but I had them available via FaceTime in case we had any issues during the procedure. And so you decide what your level of comfort is, but they make sure that you're supported during that process. Some other areas that are touched on by the guidelines, and I won't go into them too much because I think there's other talks that are dedicated specifically to these situations, but RFA is considered second line for PTC, or papillary thyroid cancer. There's evidence that it can be done safely, and for some people, or for patients that are not considered surgical candidates, it could be an appropriate treatment. But especially early on in your practice, I would recommend starting with these because it definitely requires a higher level of skill to make sure that the entire nodule is adequately ablated. But the guidelines do say that it can be done and that it should be followed, including following thyroglobulin, assessing local regional disease status, or assessing the lymph nodes to make sure that there's no sign of cancer spread in that post-ablation period. Following it like you would follow any other thyroid cancer, of course. Same with toxic thyroid nodules. This is, I believe, is a great treatment for autonomously functioning nodules. But you do have to counsel the patient that, of course, there are other therapies like lobectomy or REI that have a higher initial efficacy rate. And so for the patients that have good reasons to not want to pursue hemithyroidectomy or have good reasons for not wanting to pursue radioactive iodine, and many people have very legitimate reasons why they don't want those treatments, this is a great alternative therapy that doesn't have some of those important downsides. This other set of guidelines, sorry, I didn't include the link for it, but this was from the European Thyroid Association paper, kind of specifically sets the large autonomously functioning nodules apart from the small autonomously functioning nodules. I think that they found that the larger the toxic nodule is, the more likely it is that you're not going to get normalization of the TSH, especially with a single session of RFA. And so just being able to distinguish the volumetrics of the toxic nodule is an important thing. These are some of the things that you might follow in the post, the pre and the post ablation period. Quantitative measures, volume reduction ratio, VRR, thyroid function, TSH. For toxic nodules, perhaps you're going to get an iodine scan pre-procedure, and maybe if you don't get volume reduction, perhaps post-procedure too. You're going to be assessing their symptoms. You're going to be assessing their cosmetic changes in their neck, how protuberant their thyroid is. And then there are quality of life questionnaires like the ThyPro and the SM36 that have been used to kind of track how much people are suffering from compression symptoms. Thank you. I hope I did okay on time. Does anyone have any questions? Yes?
There you go. I just want your talk. Tell me what your protocol is for anxiolysis for the patient.
Yeah, so typically it's an oral Xanax, usually it's either going to be 0.5 milligram or 1 milligram given an hour before the procedure. I found that for some people that are either older or smaller or are benzodiazepine naive, the 1 milligram could be a little much for them. And so I've kind of taken to actually prescribing them 2 0.5 milligram tablets, and then I'll tell them to take a 0.5 milligram at a time and just kind of see how they do. And I just make sure that they have a ride, they're not driving for the rest of the day, and that that you complete your consent and your pre-procedure discussion prior to them taking the Xanax.
And what are the anticoagulation guidelines with regards to the ablation?
So in general, I would avoid, and I'm not sure exactly if this procedure touched on what the exact guideline statement is, but I would avoid doing these procedures under anticoagulation. I know that the data for FNA biopsy kind of supports that you can safely do FNA biopsies on anticoagulation, but I would say early on, my opinion, and this is not reflected in the guidelines because I'm not sure what they state, would be to avoid doing this procedure on anticoagulated patients, especially early on. I usually ask patients to pause their anticoagulation for a similar amount of time that I would ask them prior to surgery.
Does that include dual antiplatelet therapy?
Yes. Yeah. What's that?
Does that include dual antiplatelet therapy? Stop that.
Yes. Although, I think in patients that are on a baby aspirin and that have significant reasons why they wouldn't want to pause that, I probably would be okay with that. But I think especially early on in the program, I would avoid doing it on Plavix or Brilinta. Yeah.
And for your follow-ups, when you're doing your volume measurements, are you actually just doing that now at the time of a clinic visit, or are you ordering a thyroid ultrasound diagnostic scan ahead?
I think it depends on how your clinic workflow is. I have a physician assistant that works with me that sees a lot of the RFA follow-ups. I think as you continue, if you start to get busy with your RFA practice, you might find that seeing all of these patients, especially at 4 set points throughout a year and doing an ultrasound every single time, will fill your clinic very fast. And so initially I was, because I was tracking my own outcomes very closely, and I wasn't as busy at that time with all these. And then the more patients that came in, the more we had to follow, the more that we had to put them off. But our clinic, we follow them all ourselves because the radiologists aren't going to necessarily calculate the tumor volume or the volume change, which is the really most important thing you need. And also they're going to sometimes if they're not aware that this has undergone an ablation, they're going to call it as highly suspicious. because normal post-ablation changes mean that the borders might be irregular, it's gonna have, deeply hypoechoic in the center, and these can translate to a high TIRAD score. And so you need to make sure that if you order a radiology ultrasound, and have it done, that you communicate clearly with the radiologist that the patient is post-ablation.
Do you see any, is there any codes for billing, like for the insurance companies?
For billing for the ultrasound or for the
You know,
ablation?
for the RFA procedure.
Yes, but that's a completely different talk, and it's going to change soon. Right now, there's no dedicated CPT in the United States for ablation, but there will be in 2025.
So what do you use?
There's a couple comparable codes. I forget the exact one that we use, but we use an ultrasound guidance code, and then we use an endocrine procedure code. I can tell you later.
60699.
Yeah.
60699.
60699. Yes.
So I have a question about cystic solid nodules, like the complex nodules.
Mixed cystic and solid. Yes.
So many times when you do FNA, you actually aspirate the cystic portion then, right? So would you wait to see if that improves the symptoms, like the compression symptoms or the cosmetic? And if you say yes, then how long would you wait to determine the candidacy for the procedure? And what's like the overall incidence of these complex cystic solid versus your just solid or just cystic?
Yeah, that's a good point. I think in general, if you can do a less invasive procedure for them, like a simple ultrasound guided cyst aspiration, that's going to be effective for them, by all means do that. And there are situations with cysts that we will just try to drain it, give it time. But we do know that simple ultrasound guided cyst aspirations without ethanol or RFA have a very high recurrence rate. Yeah, I would say if it recurs, then that would be an indication to proceed with ethanol or RFA.
And what's your protocol for ethanol?
So I don't do ethanol. I just do RFA. So if it's a pure cyst, then I would refer it out. We're trying to launch an ethanol program, but we're actually having some trouble getting the medical grade ethanol right now.
And what's your post-procedure protocol? What do you send home, like patients with, like what medications are there?
No medications, just Tylenol or Advil and ice pack. Alex?
For the toxic nodules, how soon and how often are you checking thyroid function?
Yeah, good point. So for non-functional nodules, we're typically doing one TSH check after the procedure. Again, I'm not saying this is just what we do. For functional nodules, we're watching it more closely. And so typically at each check throughout the year, we're getting a thyroid function panel and TSH check. And so that could be a 1, 3, 6, and 12 months, and then yearly after that. Thank you.